Good evening or good morning, depending where you are in the world. This is Dave Meinhard. I work with the Vattikuti Foundation in Detroit, and I'd like to welcome you to this Vattikuti Webinar Series program. And we're fortunate to have Dr. Rama Joshi and Dr. Anupama Rajanbabu with us today, as well as Vattikuti Foundation CEO Dr. Mahendra Bhandari. And we're going to be talking about the complex ovarian mass and minimal access robot-assisted surgery. It's an important topic, and to introduce our presenter, here is Dr. Anupama Rajanbabu. And I've known her for many years over the internet. She's worked actively with the Foundation and the Robotic Surgeons Council of India. And so I want to thank her for joining us today. And without any further ado, we're going to go ahead and let her take over. Thank you so much for being here.
Thank you, Dave. Thank you for the fine introduction, and thank you, Dr. Bhandari, for making the foundation do this outreach activities. This year, because of COVID, we are all in our places, unable to travel, and this is a good forum for us to interact and share new knowledge. And here I would like to, today we have an interesting topic, and we have a fantastic presenter, Dr. Rama Joshi. He's my friend, and she's a senior consultant in Gynecologic Oncology and the head of Department of Gynecologic Oncology at Fortis Hospital, Gurgaon. And she's been doing robotics since the last 6 years and have done many number of surgeries. And today will be very, very interesting. So we'll listen into what Dr. Rama Joshi has to say.
You and the Vattikuti Foundation. It had always been a matter of pride to really attend the Robotic Surgeons Council meeting of the India. And we had been given the opportunity, and we basically had great discussions and great learning during this conference always, and we always remember you for that. So thank you for the opportunity. And the topic given to me is the complex ovarian mass and the minimal access robot-assisted surgery. I have chosen this topic because it's very, very controversial. Once we talk of the complex ovarian mass, actually there are many challenges which come in front of us. And majority of the even GYN oncologists you will find to say that once it is complex ovarian mass, there is no role of minimal access surgery, be it laparoscopy, be it robotic surgery. But I think with the technical advancement in the surgery, we are able to achieve some of the principles, we are able to follow the principles, and we are able to achieve whatever we wish to. May not be with that, I mean to say, we are not inferior to any of the open surgery, and rather the precision is far better. So the question comes whether this complex mass is benign or it is malignant. It's only because of this question, which requires to be answered, that we have to respect the excision of this particular complex mass, because this can be malignant. And we have to predict when the complex mass is there, what is the histology, and especially when it is limited to that of the ovary. Surgical approach can be either open or the minimal access, but of course with that of the challenges. And it's important to understand how does this robot-assisted surgical approach differ. And it is important to have the proper counseling of the patient, to counsel the patient that it can be benign, it can be malignant, whether we are operating these patients with that of the open surgery or minimal access surgery. So we always take this mass as presumed ovarian cancer, because majority of these patients, they present with that of the vague complaints of the bloating or some kind of the abdominal discomfort or the pain or feeling of full quickly. These are the dyspepsias with which they present, and majority of them will present to even the GI physicians. On ultrasound or imaging of the CT scan, they come up with that of the complex ovarian mass, and then they are being referred to the gynecologist or the gynec oncologist. And when they have the CA-125 also elevated, of course, this is taken as that of the presumed ovarian cancer. So these are the kind of the masses which they present with. I mean, to say simple ultrasound with that of the Doppler can show the solid areas with that of the increased vascularity, or they are the bilateral masses and these are the complex masses. And that's how the simple, you can say the mass can be septated. And we really do not know how do these masses, I mean to say what is the nature of these masses, whether these are malignant or these are benign masses. So that's how another actually very important finding is maybe there's some kind of the solid area in any particular, you can say this ovarian mass, this is what is the CT scan of the patient. And once you find that, yes, this is what is the projected solid area, this is what is a nodule here, we always have a suspicion that this may be a cancer. So when we are dealing with these kind of the cases, of course, this presents a major surgical challenge. The challenge is of the spillage because we are concerned when it is malignant and we are likely to upstage this particular disease, which is confined to that of the ovary. We do not really want it because otherwise it is likely to, you can say, alter the prognosis of the patient. And we are also concerned, so far as the oncological, you can say the detailed of the histology are concerned, because we need to preserve the anatomy of the specimen. So there should not be any distortion. And we should be able to read the histology or know the histology optimally to consider what exactly the stage it is. We are concerned about the capsular involvement. We are also concerned about any kind of the breach in the capsule, which was there even before performing this particular surgery, so that we can stage these patients properly and then accordingly can know what should be the optimal adjuvant treatment in these patients. And unfortunately, when these patients present with that of the masses limited to the ovary, we cannot have the biopsy. And that is why here we have to excise the mass and send it for frozen section. And it is this frozen section which gives the decision of the optimal surgical staging on table when we know that, yes, it is malignant or it is a borderline tumor. Of course, the surgery varies, surgical staging varies when it is invasive ovarian cancer. So ultimately, our main concern is that we are concerned about the oncological safety, oncological outcome, as well as the quality of life of these patients, how we can optimally deal with the situation and how we can go about. So when we are looking into the various age group, we find that in about 13% of these patients with the premenopausal, these masses are likely to be malignant, and 45% in a postmenopausal patients, these may be malignant. So I think we have to be more careful while dealing with these kind of the masses in these particular age groups. Sometimes, of course, we find that even the size of the tumor is about 5 centimeter or even smaller than that. There is still about 3 to 18% chance of the mass being malignant in the postmenopausal patients. Histological distribution, when we are dealing with these masses in the adolescents, we find that the most common is the germ cell tumor of the ovary, or these are the epithelial stromal tumors, or these are the stromal tumors of the ovary, and otherwise the miscellaneous tumors. So I think here also about 25 to 30% of these patients will have the malignant ovarian masses. This is what is our concern. Why are we concerned when it is malignant ovarian mass? That when it is taken as stage 1, you will find that there will be bifurcation. There is bifurcation of the stage 1 itself. Stage 1A, stage 1C. And once it is stage 1C, of course, the prognosis is comparatively poor. And survival is significantly less than that of stage 1 tumors. And stage 1C, again, it bifurcates into 1C1, 1C2, or 1C3. And similarly, the outcome or the survival. So that is why we are concerned even when the disease is limited to the ovary, we should keep this thing in mind. In order to give the best in terms of the survival to the patient, oncological outcome to the patient, we have to deal these masses very, very precaution, with a lot of precaution and respect. So while evaluating these masses, we consider what is the age of the patient, and clinical evaluation is very, very important, not only the imaging, but also clinically, to select that how we can go about the surgery, what approach we should really be choosing in these patients. Should we go for the open? Should we go for the minimal access, robot assisted, or laparoscopy, whichever the facility you have? It's a very important question. And for that, I think we always go for the imaging as well as the tumor markers and frozen section, as I've already mentioned. Simple ultrasound IOTA group has already revealed, that these are the markers which one require to consider for that of the M rules. And if suppose the single point of the M rule is there, then you have to be cautious that, of course, there is a likely chance of it being malignant. Or when there is none of the features seen from that of the M rules, then of course we can assume that these are likely to be benign. And of course, the sensitivity is very high. But still, the frozen section plays a very, very important role to define. And when we see that what is the sensitivity, what is the specificity of predicting, or rather the frozen section defining the borderline tumors, this is quite high when it is the malignant tumors, varies from 96 to 100%. But again, it varies from center to centers. Some of these centers, you can say the sensitivity of diagnosing the malignant tumors is significantly, it may be much less, maybe 85% or 90%. It all depends on the workload of these centers, but it has been reported around 85 to 100% is the sensitivity of picking up the malignant masses on the frozen section. Based on this, we decide for the surgical staging, because staging is important in these patients once they are reported as malignant. Treatment decision is taken whether we have to go for any adjuvant treatment or not. What is the grade of the tumor? What is the stage of the disease? And also the prognosis is explained based on the stage of the disease. We can compare the treatment results only when we accurately stage these patients. And some of the patients can have the participation in the clinical trials. Upstaging, in cases where the disease is supposed to be limited to the ovary, it has been shown that as the grade is high, there are more likely chances of upstaging of this tumor, which otherwise we think that is limited to that of the ovary. In grade 1, about 16% of these patients are upstaged. And in grade 3, about 46% of these patients are upstaged to that of stage 3. And stage 3, once it is stage 3, these patients will require the adjuvant chemotherapy, as well as their prognosis will be far inferior than that of the stage 1 disease. On the other side, we can also diagnose here, rather pick up the patients who are likely to be in stage 1 of the disease and where we can omit the adjuvant chemotherapy. Thus, we can improve the quality of life of the patient and we may actually refrain from giving chemotherapy, which is unnecessarily be just because of the incomplete surgery. So it is important for us to understand that it is the proper stage of the patient, which is very, very important of the disease. And that is why actually here comes the role of the reference to that of the GYN-ONC based on this ACOG recommendations. And there are two ways the early ovarian cancer presents. Either it is completely staged or it is incompletely staged. When it is completely staged, there is likelihood of the residual disease is almost nil. But when it is incompletely staged, there is about 24% of these patients are based on, of course, the grade of the disease, as I have already mentioned, then about 45% of the cases of the higher grade, there can be the residual disease in these patients. And it has shown in this action trial that basically all patients who had optimally staged and in the observation arm, there was no difference in the survival. And those patients who were not optimally staged, there was a significant difference in the survival in these patients. And it is based on this, actually, the standard of care is to go for the surgical staging. When we are talking about the surgical approach to these patients, spillage is a major issue with which we are really concerned whenever we are going for the surgery or offering surgery to these patients, be it open or minimal access. There have been certain studies which have come up with some of the data that does the spillage occur in the open surgery or not? Open surgery also, there is spillage. And this is what was the study of 35 patients, or where they had compared the laparoscopic to that of the open abdominal staging for the early ovarian cancers. And of course, the 6 patients did have the spillage during surgery in laparoscopy, and 4 patients in open surgery. And this was not significantly different. Of course, the numbers are not that great, but looking at actually the experience of the laparoscopic surgical staging, that is minimal access, of course, these did have the longer operative time. They had all shorter hospital stay, and also the post-operative complications were lower than that of the open. They again looked into the 5-year disease-free survival as well as the overall survival, and these were not significantly different between the two groups. The blue line, which you see here, is the laparoscopy arm, and red one, what you are seeing here, is the open surgery arm. This paper was very interesting because they did have the meta-analysis of the various studies available, which had looked into the spillage, with which I think we are really concerned for at the time of the surgery, when we are offering that particular technology to these patients so that we can minimize the spillage. And here, I think there was no difference, actually, whether it was open or it was minimal access laparoscopic surgery. So spillage was in open also, as well as in minimal access laparoscopic surgery. And this was not of significant difference. And similarly, the patients were upstaged in both the groups. And this was, again, not of significant difference. After this, of course, the robot-assisted surgery, and it was in 2011 where the Magrina basically had published the first study of the robot-assisted surgical staging in patients of the early stage ovarian cancer. And here she compared with that of the open in 119 and 27 laparoscopy, and oncological outcomes in terms of the progression-free survival as well as the overall survival was very similar between the groups. But it had actually the advantages, robotic surgery had the advantages even over that of the laparoscopic surgery. Of the operating time, of course, was significantly longer in the robot-assisted group than that with that of the laparoscopy or the opener. But the estimated blood loss, length of hospital stay, and conversion into the, actually, as compared to that of the other groups, it was far better. Later on, the other studies by Nazat and also the Brown et al., they basically had also concluded that the robot-assisted surgery was superior than that of the other, actually, the technologies. Now here I'm going to present one video, which basically in a case of a very young girl. And this young girl was 18 years of age. She was unmarried. And it was the incidental finding of the complex right ovarian mass. Her CA-125 was 118, CA-19.9 was 4,020, CEA was normal, and rest of the other germ cell tumor markers were normal. The contrast-enhanced CT had shown that it was a large, well-defined soft tissue mass lesion of 18 centimeters into 13 into 12 centimeters in the pelvis, and which was extending into the abdomen. It did have the eccentric coarse calcifications. So this is what was the history. And with this, actually, the diagnostic laparoscopy or laparoscopic evaluation was done. As a matter of the protocol, we take up the patients for the robot-assisted surgery and confirm it on the table of all the ovarian cases where we think that we can give them the advantage of the minimal access robot-assisted surgery. We always go for the laparoscopic evaluation of the entire peritoneal cavity. And when we see that there is no disease which is extra ovarian onto the peritoneal surfaces, we take these patients up. When we are satisfied that yes, we are going to extend them, you can say the oncological safety, then only we go ahead with this. With this, I'm presenting this video. This is 18 centimeter mass. And after the evaluation of the peritoneal cavity, we did not find any disease. And we decided of going ahead with that of the oophorectomy. And this was a huge mass, so it was a challenge in front of us that how we can offer the oncological safety to this patient. Here you can see that the tubal mesentery is being separated from that of the ovary. You can very well see the precision. And I have not touched this mass yet. And whatever we think that the minimal access surgery, whether it is going to provide exactly the same or not, you can very well appreciate here in this video. The challenge was that how to really take this mass out and avoid the surgical spill. We use the Euro bag in this patient. The size of the Euro bag is about, say, 28 centimeters into 17 centimeters. So this mass was around 20 centimeters, 18, 19 centimeters. So we had chosen this because none of the endo bags are available out of this size. See, so precisely, so actually we are able to put this mass into the bag. And then the bag was taken into the assistance port. Here we had given a small nick. And then we aspirated all the contents. What is important is to see that there is no anatomical change so far as this mass is concerned on its external surface of the ovary. You can see that this is how we had noted that there was no change, and the blood loss was just 5 milliliters, and this patient was discharged on postoperative day 1. So actually, whenever we are doing this kind of the procedure, her final histology had shown that it was the mature teratoma with the foci of the immature teratoma. So we really do not know. Sometimes in the germ cell tumors also we can have the mixed germ cell tumors, and we may have to go for the definitive treatment. This case was discussed in the tumor board, and since it had only the foci of the immature teratoma, we had taken all the oncological principles. This patient was not given any chemotherapy or any adjuvant treatment. There is another video which basically I just want to extend in order to show that this was a patient of the 79 years of the age. She had a lot of comorbidities and then opted for the minimal access robot assisted surgery. And here is the video where we had done the surgical staging in this patient. And that is again of the complex ovarian mass. Here also you will be able to appreciate that how we are going ahead. You can see the laparoscopic evaluation of the liver surface, under surface of the diaphragm, the omentum, you can see the stomach, and also the paracolic gutters, and then finally the pelvis. All these adhesions were excised. That's how I think what one requires to see is that the precision and also whatever, here is the mass. So we had decided of taking this mass up. And again, we removed this mass first. And here the fallopian tube as well as the mass, both of them were removed. That is salpingo-oophorectomy was done. This mass was handled very gently. Of course, the window was created in the posterior leaf of the broad ligament, and the infundibulopelvic ligaments or the ovarian vessels were clipped. And this mass was dissected from the uterus by excising this ovarian ligament. This was again put into the endobag. And you can see this handling very nicely. We can really respectfully, we can remove these masses. Then this was clipped and this was left in the peritoneal cavity as such. And the surgery of the hysterectomy was completed. Along with that of the hysterectomy specimen, we had sent this specimen for the frozen section. So the hysterectomy was completed. Here you can see the bladder is being dissected away from the cervix, and we are able to see that the vaginal vault, and now the uterines have been cauterized and cut. This was done onto the left side. I usually like to use the clips at the uterines, and the vaginal vault is excised. Vaginal vault excision is completed. I usually like to cut the infundibulopelvic ligaments at the end of the procedure of the hysterectomy. Hysterectomy specimen is also being placed into the bag. And we can retrieved these two through the vagina. After the frozen section revealed that this was the low-grade ovarian cancer. Looking at the age of the patient, we decided of going for some modification in the surgical staging. And we had gone for the complete omentectomy and pelvic lymph node dissection. On imaging, the paraiotic nodes were less than a centimeter, were not about, say, 6 millimeters. And this patient did have the PET CT. None of the nodal areas or any other area into the peritoneal cavity or otherwise had any lighted up lesion, or these were not of any suspicion. So we completed the surgical staging in this patient, had put this, again, the omentum was put into the bag and was retrieved through the vagina. Taken the multiple peritoneal biopsies also. So oncological safety, we always follow whenever we are dealing with such masses, whether we are doing this surgical staging or otherwise in excising these masses, putting them into the bag and retrieving it through the vagina or through the abdomen, so that we can prevent the spill. And that's how I think we completed the surgical staging in this particular patient. She has completed 4 years and we followed her up, I think 1 month ago, and she is disease-free. She was not given any adjuvant treatment as the stage of the disease was stage 1A. With this, I think I thank you for your focused attention and will be happy to take up the discussion if any.
Thank you, Dr. Rama, for the excellent presentation. It was nice to see the videos, how you managed to take those masses intact within an endo bag. Before I take on the panelist questions, I would like to ask one question how do your pathologists feel when you're when the tumor is aspirated and there is a rent? Would they classify it as a 1A or a 1C? And
no,
how do you tackle it?
Here we don't actually poke in. We just give a small cut, which is a clean cut. If suppose by pathologists, they don't, I mean to say, have any doubt because they are taking sections from that cut also when they see that there is no disease onto the surface. And it's a clean cut, which is the cut which is given by using the knife. It's a very sharp cut. So there has not been any kind of the, you can say, the dilemma in stating the disease as that of stage 1A disease.
Okay, so they'll label it as 1A instead of 1C1. They label
why
it as
1C1? Because there was no spillage inside the peritoneal cavity. It was we have the kind of bag which we choose. There is no doubt that can be any kind of the spillage anywhere else. So I think we require to modify it, the technology to that extent that we are sure what we are dealing with is not going to give rise to any kind of compromise so far as the stage is concerned.
Yes, let me see if there are any questions. I think Dave has asked, it is interesting to see the care taken to keep the tumor intact. Is this the new standard? To avoid the
I think so. It should be a new standard. This is what I think. The majority of the time we think, if suppose we follow the principles, then in that case, there is no question why we should not accept this as one of the new standard of care.
Dr. Ruma has asked, if the capsule is intact but there is ascites on initial inspection, would you still proceed with the minimal access surgery?
Yes, very much. If there is ascites and there is no gross disease which you are able to see onto the, you can say, the omentum or to the peritoneal surfaces, ascites, how much ascites it is, what kind of the ascites, how does the surface looks like. But yes, you can, because there are now number of the publications and the studies which are looking into even in the advanced stage of the ovarian cancer. There was the publication from Canada, Walter Gottlieb, and I think he's also doing, even in the advanced stage of the ovarian cancer, if you are able to extend the similar extent of the surgery using the robot, one can go ahead. This is what, but personally, what I feel is till we have more and more evidence available so that we can satisfy that yes, we can adopt this technology in the advanced stage or not. So presently, I believe that we can extend the best of the care by giving the robot assisted surgery to the patients where the disease is limited to the ovary. Even when the ascites is there, we are not sure whether this ascites is having any kind of the malignant cells. The other one is that sometimes these are the stromal tumors. These can also be associated with these ascites. On the other hand, even if it is stage 1C disease, I think one can go ahead with that of the robot assisted surgery.
Another question is, are you dual docking for the paraortic lymphadenectomies when you're doing it robotically?
I think no, we are not docking, dual docking for the paraortic. We start from that of the pelvic and we come up towards the aortic.
There's a question on how reliable is the frozen section?
I think in our institute, I will say that it is 99% reliable frozen section for the invasive malignant ovarian cancers. What do you think, Anupama? What does your center says that, I mean to say, how much reliable it is?
Yes, we have published our results also back in 2015 about frozen section in epithelial ovarian cancers. For predicting malignancy, yes, excellent in serous and endometrioid pathologies. In mucinous, across the world, we have seen that frozen section is not as good as serous when you're predicting serous cancers. So when you have a mucinous cancers, frozen section reliability drops to about 70-75%, but otherwise it's 99%.
I agree with you. These are the histologies where that is why it is not 100%, 99%, yes. I would say, because when we also analyzed, we found that, of course, it was 99%, 99 point something percent, because I think 1 or 2 or 4 cases, this could have been one of the possibilities in the histologies, like you, as you said, mucinous. And sometimes I think we have come across a borderline. Also, in one patient, it was a borderline tumor. It was reported as borderline, and then it turned out to be the invasive or the well-differentiated carcinoma.
Yes, sometimes it is in that there could be one area of invasion which frozen section could not catch.
Yes.
That would need detailed sampling. I think till they ask further questions, I'll keep on the questions coming. What are the biggest size? Your urobag, you have a urobag, and what is the maximum size of the tumor do you think that will fit into the urobag?
I think I took out the maximum size was this, that was 18 centimeters, 19 centimeters tumor. It's a huge tumor. And you could very well see that urobag could accommodate this tumor well. And if the tumor larger than that of the 20 centimeters, I don't think so one is going to use the urobag also, because urobag too will be small, and I don't know whether we'll be able to really choose this kind of technique with even with the larger ovarian masses, more than that of say 20 centimeters.
So what we agree is the limit of doing MIS for ovarian masses is the size of the bag that we can fit the mass in intact.
Yes. What I feel, Anupama, is that it is the, if we select the patient properly with our clinical evaluation, imaging, and also on the laparoscopic evaluation, and we take full precautions, then definitely it is feasible.
Yes. And I've got a comment from an attendee. I think we have a more safe bag for larger masses. I think that is used for the myoma morcellation, that bag. Again, I have not used the bag for any purpose, so I cannot comment on the size. Madam, have you seen that mask? I don't know, because we are not doing that myoma. I don't think you also would have used that bag.
Yes. Actually, that is, people are using it for morcellation. That is why it is known as MorSafe bag.
Yes.
And to retrieve the mass, I don't know how to retrieve the mass through that without actually morcellating it. So we are not morcellating the specimen, and we are bringing it towards the, you can say, the assistant ports, giving a very fine, clean knife nick, and then aspirating the tumor.
So this was brought out through a suprapubic, or which port was, where was the port?
This was assistant port. I think I had shown in that. It was through the assistant port only.
Okay. It was at the Palmas area? Or,
yeah. Not the Palmas area. It was, left. I think, in the flank, on the left side.
Flank. Left lower.
Yeah.
Another question is, can complete omentectomy up to the splenic flexure be done robotically?
What?
Can you do complete omentectomy robotically up to splenic flexure?
Yes.
There is no there is no limit to omentectomy or lymphadenectomy. There is no comparison between if you are doing robotic also, or whether you're doing open, you can do the same surgery. Momentum. Only concern was the peritoneal deposits, like peritoneal spillage or peritoneal deposits. If we can clear that out, then there is no limit.
Yes. So
what do you think?
Technologically, as you get more and more experience, you will be able to actually to do the surgery as you are doing it in open, and you can actually do almost the similar procedures in the way you go for. But many of the redocking and the double docking and all those things can also be used whenever we are doing any kind of the procedure into the upper abdomen, and it depends on how comfortable you are in using the double docking and then upper abdominal surgery. It varies.
I do regularly double dock when I'm doing ovary for the upper paraotic as well as omentum also. It is it can be cleared very well. When
omentum also can be double docked. Yes. Omentum also can be double docked without any problem. Yes, you can do that also. We have done in some cases double docking also. As you mentioned about the paraotic especially, this is what my concern, I mean to say my answer was that for the paraotic, we have done the double docking also. We tried double docking once, and otherwise it can be done with the similar, but not the omentectomy. Omentectomy can also be done.
I think there are no further questions now. So it was a very interesting session. It's something which complex ovarian masses and minimal access surgery is not something people take in the same breath. They always feel that minimal access surgery is bad for complex masses. But it is the way you do minimal access surgery is important rather than saying that minimal access surgery is bad. Because following these principles, the oncological principles, is very important, as Dr. Rama Joshi has shown how the survival differences are there when you don't follow the surgical principles or there is spillage. So following the principles is the most important thing, whichever method of surgery that you're doing. Even in open surgery, we have seen multiple times a big ovarian masses are taken out through a small fan steel incision. That does the same amount of damage that you're doing. So making a small cut and taking out a big mass by spilling it is not an option. Better contain the mass and take it out without spillage for the patient. Right, madam?
I wanted to make one comment.
Yes.
Majority of the time, what I have seen or what we have seen in our practice is that whenever the mass is being retrieved through the laparoscopy, then first thing done is that they aspirate the mass within the peritoneal cavity. So if we change a little bit in our practice, that we don't aspirate the mass till we put it totally into the bag, and the bag should be strong enough to really protect any kind of the spillage. And then we go scientifically to make a small nick and then aspirate. Then of course we can give the proper specimen to the histology. For the histology, this is very, very important, because even if we cut, none of the histopathologist is going to give us the correct, you can say, the histological features, whether the surface tumor on the surface, or I mean to say the other histology. This is what is very, very important point, which I think we can change our practice. And once we do it, then it cannot be made a generalized statement that for the complex ovarian large mass, we should not go for the minimal access surgery or minimal access robot assisted surgery.
That is, choosing those patients and doing the correct surgery for them is important, and maintaining the oncology principles. I think that is the most important thing that you are telling today. It's not the size of the mass or complexity of the mass, but you have technology to take this out intact and give a good quality of life to the patient without compromising her survival. Then you can do it. So if there are no further questions, I think we can conclude the session now. Dr. Bhandari, sir, I think we would like to hear from you.
Yes, thank you very much, Anupama. And Rama, thank you very much for responding to our call at a click, as if you are next door, and we bank upon you for dissemination. And it's really a treat to listen to how Rama's growth in minimally invasive oncology has happened. Not that when I met her first time several years ago, she was already an accomplished cancer surgeon. I would like to make few comments. In urology, for prostate, conventionally, we used to say which technique should be done, open or laparoscopy or robotic. And Whittle Martin had written that the decision to use a technique depends upon three things: size of the patient, size of the tumor or prostate, and size of the surgeon. Size of the surgeon doesn't mean BMI of the surgeon. And that's what Rama tried to say, that surgeon has to introspect and see what he is competent and confident to do. I don't care minimally or maximally invasive surgery as long as you have a respect for the cancer. And that is the point she was repeatedly trying to emphasize. And to younger colleagues, I would like to say that tissue respect I learned from my working with the plastic surgeons. And you should see how they are able to take the flaps without touching it. So I think cancer surgeons have done enormous things, and I think it's a sea change. I have associated in my career several times with gynecologists to remove these complex pelvic masses where the bladder was involved or something, bladder was adherent. And in open surgical techniques, I have found sometimes they're so difficult because they are so scirrhous in nature, totally adherent to the common iliac vessels and all. And even the knife would not work. Energies were not available at that point in time. From there, I see that this is a myth, or this is illiteracy to say that robot or laparoscopy or minimally invasive surgery is not, because usually we find a statement from cancer surgeons who are experienced open surgeons, no, robot is not for us because we deal with very complex cancers. Obviously, this criticism comes from those who have not seen both sides of it. So one acid test is, if somebody criticizes to me about a technique, first thing I would like to know, is he well versed with both the techniques or not, or it is his comfort zone problem? So I think it's a great lecture, great videos, and we look forward to bring in. I'll announce here because I think 2020 was a total washout for the foundation. Thanks to Dave and Joanna that we kept our flag flying with these webinars, educational webinars, master classes, and patient webinars. 2021 also looks to me like that, and that's why we have already drawn a calendar for bringing in the best of talent, international, for the benefit of our postgraduates and younger gynecologists, and create a B2B discussion amongst the experts. And we will have almost 40 to 50 such programs next year. And we look forward to not only for you to continue to participate, write to us some cutting edge areas, because we don't want to be one of the commoners. So many webinars are stuffed in, but we want to be different. We want to give in something which others can't give. So please give your suggestions on what subjects we should take, and do propagate amongst your postgraduates and all, and we will run some postgraduate courses. And anyway, I'm never possessive of the number of people, because even if I teach one intelligent or interested person, I have done my job. So we are not the person. The moment we chose specialties, we left the crowds behind. So thank you very much for sparing your time on this Saturday evening. And thank you again profusely on the behalf of the foundation, and look forward to have you again. In the meantime, stay safe with COVID. Don't be complacent, because there is a fatigue phenomenon, and we are following. We are sending vaccine soon to you. Thank you very much.
So nice, sir.
Thank you.
Thank you very much, sir.
Okay, I wanted to just thank Doctors Joshi and Rajanbabu again for all the work you put into this program. It was a very interesting presentation. I, of course, appreciate as a patient, Dr. Joshi's concern to make sure that her patients are informed well about what procedures are available and why she does what she does. That's important. And I know everyone on the patient side of the position, feels the same way. Thank you for that. And I want to take this time to wish everybody a happy holiday season and a happy new year. Our webinars will resume shortly after the first of the year. And we're also, as Dr. Bhandari said, we're going to have a very ambitious program of webinars and master classes. And look to our website, and we'll be publishing a schedule shortly. This video will be available next week on the Vattikuti Foundation website. There's instructions on the chat window, a link there. So, doctors, thanks again. I appreciate your time this evening.
Thank you so much, Dr. Dave.